Hello everyone. Today we will be talking about a case titled Unbilling the Forgotten, the crucial role of LV gram in STEMI management. Introduction. Left ventricular wall rupture following ST elevation myocardial infarction is a rare but a catastrophic complication. LV wall rupture presents as a life-threatening emergency due to the rapid progression to cardiac tamponade or free wall rupture into the pericardial space, leading to a hemodynamic collapse. Prompt recognition and emergent surgical intervention are crucial for improving outcome in affected patients. In patients undergoing myocardial infarction treatment with modern reperfusion techniques like PCI, the occurrence of the LV aneurysm has not been extensively studied. However, the frequency is lower compared to the era of thrombolysis therapy, when the LV aneurysm was about 7 to 19% of patients with U-wave myocardial infarction. Our case is a 79-year-old Caucasian male with a medical history of ischemic heart presented to the hospital for acute chest pain that was described as substernal, 10/10 in severity, and it was similar to what he experienced in the past, with a partial improvement after sublingual nitro. The pain first occurred 1 day prior during exertion and was relieved with rest. He has a history of CAD with prior PCI to the LAD, left circ, followed by 3-vessel cabbage with Lima to LAD, saphenous to the RC and to the OM branch. Physical exam showed patient in moderate distress with elevated blood pressure of 141/77 and a grade 3 systolic murmur at the second and right intercostal space. No thrills or rubs were detected. The ECG showed ST elevation and the cath lab in the lateral lead, and the cath lab was activated. In the cath lab, the patient received nitroglycerin, aspirin, and double bolus of eptifibatide. Findings were severe, native 3-vessel coronary artery disease with patent bypass graft and an occluded distal LAD beyond the anastomosis site, with TIMI flow of 0. This culprit lesion underwent angioplasty, and later on, left ventricular graphy was done, and the catheter was advanced across the aortic valve to the left ventricle under fluoroscopic guidance. 24 ml of contrast was injected with a power injector and identified a left ventricular wall rupture and pseudoaneurysm. 2D echo in the procedure was done and showed a contained rupture, pseudoaneurysm, at the apical lateral wall. Cardiothoracic surgery was urgently consulted, and the patient later on underwent repair of the LV pseudoaneurysm via reduced sternotomy. The patient stayed in the hospital for 10 days, and his condition improved over these 10 days, and later on he was discharged with a follow-up plan in place. Discussion. This case illustrates the important role of LV gram in the management of acute coronary syndrome. LV wall rupture following STEMI remains a challenging and potentially fatal complication demanding a high index of suspicion, timely intervention, and coordinated multidisciplinary care to optimize patients' outcome. In conclusion, LV rupture is the rare but severe complication of ST elevation, myocardial infarction, arising from extensive myocardial necrosis due to coronary artery occlusion. Prompt recognition and emergent surgical intervention are critical, as rupture can result in rapid hemodynamic collapse. Modern reperfusion techniques like PCI have reduced the incidence of LV aneurysm, underscoring the importance of timely intervention in improving outcome. This case highlights the essential role of the left ventriculography. in managing such complication, emphasizing the need for coordinated multidisciplinary care to optimize patient survival and recovery.